Emilie, the last presentation is by Dr. Emilie Macher. Macher, sorry. And please, let's give you all the time.
Okay, good afternoon. So my name is Emilie, and I'm presenting a qualitative study, which was part of a master degree I just finished at the Liverpool School of Tropical Medicine. And it's about building therapeutic alliances between health workers and guardians in nutritional rehabilitation units. It was conducted in Malawi. The idea is that not all malnourished kids are the same. Great proportion of them will be now treated at home as outpatients, thanks to the ready-to-use therapeutic feeding, and will do pretty well. But for the most complicated ones, the severe ones, either because of underlying conditions or severe acute medical complications, the case fatality rates are still very high, and there is a lot of improvement that we can do. I think it's been mentioned a number of times of the importance of parents and especially mothers. And it's particularly true during the admission of a patient in a nutritional rehabilitation units. They feed the child, keep the child clean, they monitor the child. So they really have a key role in this admission period. And surprisingly, we know very little about what they think, what they feel, how much they do believe in what we do and our ability to treat their kids. And I think this is important, and particularly when it comes to the understanding of malnutrition, because protocols at the moment are strongly shaped by the understanding we have of malnutrition as a combination of lack of resources, poverty, poor access to healthcare and repeated infections, inadequate feeding, etc. But some studies in the community, and some of them were done in Malawi, showed that in the communities, beliefs could be completely different about what malnutrition was coming. And so we thought that it was important to understand a little bit better what parents were thinking, to better communicate with them, to improve the therapeutic relationships we were building with them during these long admissions. And we started by exploring the differences between their perceptions of the causes of malnutrition and of the effectiveness of the treatment with the ones of the health workers. So the study was done, data were collected recently, last summer, and the study was conducted in the Moyo unit, which is the nutritional rehabilitation unit of the relatively famous Queen Elizabeth Hospital in Blantyre. It's a tertiary hospital. It's the referral hospital for the southern region of Malawi. What we did, we combined focus group discussion, semi-structured interviews, and a bit of observation of two groups, the health workers, consultants as well as nutrition assistants, and carers who are mostly mothers. Results, so I can't share everything, unfortunately. The first thing I think is important to highlight is the importance of beliefs in the mindsets of carers. They knew, and they cited poverty, lack of resources, inadequate feeding practices. They were well aware of all this as causing malnutrition in their kids. But they also thought that malnutrition was due to God punishing them, was due to witchcraft, and also to something that is called lack of care, was found in different regions of Africa and particularly of Malawi, which has to do with the parents not following the sexual abstinence rules that are supposed to come after the birth of a child, and they have sexual intercourses either together or out of the marriage. And this came again and again, and you can imagine the impact in terms of stigma and couple relationships when your child develops malnutrition. These important beliefs, so the staff was well aware of how important the beliefs were, but there was kind of an entire negation of them in the unit. It's like you come to the hospital, then let's start, let's speak seriously. And so this completely broke down the communication and the trust from the start, and I think contributed to this competition and the lack of trust in modern medicine overall. Another finding, interesting, because I think it could apply in a number of settings, is competition between education and information. In the Moyo unit, there is a big emphasis on education, on feeding practices, on hygiene practices. Carers were aware of how important it is. They loved it, and they were eager to implement the measures they were taught when going back home. But when we asked them about medical information about the condition of their child, they knew literally almost nothing. We forgot to tell them about pneumonia, antibiotics, 6 days, these kind of things. And whenever they had received it, they understood it well, and they were very happy to have it. They were asking for more. So I think it's a lesson we can take, because it's a trend that I'm sure we can find in different places. The last point was questioning people about parents' participation in care. Everybody agreed, there was no debate about the importance of parents being involved in care delivery and the good impact on quality of care, even if it was sometimes challenging. But if we were asking about the ability of parents to be part of decision-making processes, then we got interesting feedback. Carers, as well as parents, were saying, no, doctors know, we don't know, we're not competent. But in parallel, a number of mothers gave us quite interesting examples of very realistic decision-making. Things like NG tube, or, I mean, very simple things that were very relevant and where they had been very active and had been valued and listened to with a clear benefit for the child. So I think we can use them as guides to tell us how much we could and how we could involve them in these decision-making processes. So I think I'm running out of time a little bit. No. So just a limit, besides the fact that I was clearly external to the context, although I worked with a research assistant who was Malawian, and we also looked for respondent validation, checking the relevance of our finding with the team. A limitation for this study is the generalizability, because clearly, the Queen Elizabeth Hospital is a unique context, but there were a number of features that I think could apply to many places. Now, to build a bit further on our results, we tried to come up with a conceptual framework to kind of describe the relationships between health workers and parents during this kind of admission. There are just two more things I'd like to emphasize. One thing is that there is clearly a huge impact of the environment, gender issues, gender power issues, socio-economic, cultural norms. But more than everything, we deal with individuals, and not all carers do have the same perceptions, the same beliefs, the same personalities, the same competencies, and we need to tailor this to them. The second thing is extremely basic, but is a key point. The child condition is having a huge impact on the trust and satisfaction level of the parents. How severe is the child? How well or not well is the child doing? The type of care, some people will be freaked out by a blood sample, but have no problem with oxygen, etc. So this is clearly having an impact, and this is something we should pay attention. In a word, the sicker the child, the more attention to the carer. Seems very basic, but we probably forget this quite often. So I would be happy to tell you a lot more, but I have to stop here. I think really the parents are our allies and should not be our enemies, and this is how we could improve quality of care. And I thank you very much for your attention.
Thank you very much, Emilie, and it's sometimes the most obvious points that need repeating. Do we have any questions? Yes, please.
Did you see any possible examples of child abuse in that the severe malnutrition was possibly due to deliberately withholding of food? I say this because I've seen this a lot in our experience in various countries we're working.
No, but I don't think it means anything because so it was nobody can be admitted in the Queen Elizabeth Hospital at the moment, if I'm right, without being referred from another health center. So it was not like a typical nutritional rehabilitation unit, and patients were really sick and with a high HIV prevalence in the unit. They were clearly sick from sickness, no abuse.
Thank you. Yes.
At the Global Health Institution here in Karolinska, we are very interested in this kind of qualitative research. So is it going to be published soon?
Yeah, so I literally finished it a few weeks ago, but yeah, I hope so. Thank you very much.
Let us know.
Thank you.
But I do believe, I mean, if I can comment on this, I'm not pretending I'm an expert in qualitative research. This is my first experience with this, and it's quite it's interesting and it's amazing the amount of information you get, the level of understanding you can get, and if you manage to appropriately share it, I think it can really inform quality of care and the quality improvement process overall. So after this, I'm absolutely convinced of how beneficial it can be in a world.
Thank you.